Good afternoon, everybody, and welcome to Urology Speaks. My name is Mohamad Allaf, and I serve as the director of the Department of Urology here at Johns Hopkins and the Brady Urological Institute. Many of you have joined us but previously on Urology Speaks sessions and may notice my title change. I am deeply honored to have recently been appointed the fifth director of the Brady, and I sincerely look forward to continuing to serve this esteemed institution, our patients, and the Brady team in my new capacity. Thank you for your interest in minimally invasive and robotic surgery. It's a pleasure to share the exciting advances we are making in this field and how these advances are helping deliver cutting-edge care to our patients. The advances that you will hear about today are made possible through the trusting partnership between physicians, patients, and families who all share a commitment to our mission. Our dedication to patient-centered care inspires us to ask challenging questions, improve surgical techniques, and pursue research that will create positive outcomes for this generation and for generations to come. The story of the founding of our institute actually connects very nicely to our discussion today. In 1915, a very special patient, Mr. Diamond Jim Brady, enabled the establishment of our institute through a transformative gift made in appreciation of the care he received from Dr. Hugh Hampton Young. And actually, the care that he received was at the time a minimally invasive approach to a disease of the prostate. Not quite robotic surgery, but at the time, the same in terms of cutting edge potential. Hugh Hampton Young was a trailblazing surgeon at the time and the forefather of the modern field of urology. And Mr. Brady's gift launched our institute over a century ago, but we're able to advance his vision today thanks to generous individuals who continue to support and champion our work. And now I'm going to proudly introduce you to my colleagues who have joined us today. Dr. Misop Han is the David Hall McConnell Professor of Urology and Oncology at the Johns Hopkins School of Medicine. Dr. Han is a board-certified urologist who specializes in robotic radical prostatectomy, as well as robotic approaches to kidney cancer. He received his undergraduate and medical degrees at Johns Hopkins and completed an internship in surgery and then a residency in urology also at Johns Hopkins. His research interests include the outcomes of radical prostatectomy, medical robotics, and predictive modeling in medicine. He has published extensively in these subjects and has received international and national recognition for his research. We're also joined by one of our great pediatric urologists, Dr. Charlotte Wu. Dr. Wu serves as an assistant professor of urology at the Brady Urological Institute and the Johns Hopkins Children's Center. She graduated magna cum laude from Middlebury College with a double major in molecular biology, biochemistry, and French. She completed medical school at the Case Western Reserve in Ohio and went on to residency training in general surgery and urologic surgery at Yale University School of Medicine. Dr. Wu completed a fellowship in pediatric urology at Emory University in Atlanta, Georgia, and her clinical practice utilizes a range of open, minimally invasive, laparoscopic, and robotic surgical techniques to address a broad spectrum of pediatric urology conditions. Dr. Wu joined the Brady pediatric urology team in 2020, and her current research focuses on vesicoureteral reflux, posterior urethral valve disorder, and spina bifida patients. After our presentations, we've reserved time to answer your questions. Please use the Q&A button at the bottom of your Zoom screen to submit questions at any time during our presentations or after the presentations. We will try our best to answer as many of these questions as possible. And finally, as a reminder, today's webinar is being recorded and will be made available if you would like to pass the recording along to family or friends who might have an interest in this topic. I'm going to start by giving a little bit of a history of surgery, and if we could get the next slide, please. On your slide, you see a picture of Hugh Hampton Young, who was the first director of urology at Johns Hopkins, performing a radical prostatectomy at the American Urological Association meeting. Clearly, the scene on the left side is what surgery looked like back then, and it continued to look very similar to that until recently. On the right hand of your slide is a picture of what one iteration of robotic surgery looks like today, and that is a multi-arm robotic instrument at the patient's side and a console operated by a surgeon at a distance in some ways. And this version of robotic surgery is called the Da Vinci robot, and is something that has become commonplace in urology. And at Johns Hopkins, we have one of the largest multidisciplinary robotic surgery teams in the world. Next slide. This is a graph showing you the evolution of robotic surgery by numbers here at Johns Hopkins. Dr. Misop Han, who we have the pleasure of listening to today, was instrumental in helping amongst the team of nurses and administrators and other surgeons in building this program here at Johns Hopkins. And you could see in the early 2000s, it was rare that robotic surgery was performed at the Johns Hopkins Hospital. But you could see in some ways an explosion of the number of robotic cases being performed, prostatectomy being the most common procedure we do robotically, but certainly the other colors other than blue denote other procedures that we do, and more we're applying this in our pediatric patients. The next slide is going to show the operating room. Basically, you enter the room and it looks like every other operating room, but if the camera were to turn to the left, we would see this robot, and the console is tucked in all the way on the right-handed corner behind those monitors, and the patient would lie on the table, anesthesia would be induced, and then we would make small 8mm incisions in the skin and use that as a portal of entry into the body. The robotic instruments then dock onto these 8mm, what we call trocars or port sites, and we're able to do the entire operation through 3, 4, or sometimes 5 small 8mm incisions. And this leaves minimal scarring and has been shown to result in faster recovery, in many instances better visualization, and less blood loss than one would experience in open surgery. Next, I'm going to turn it over to my colleague, Dr. Misop Han, who I believe will share his slides and will share some with you his work on an exciting area of urology, and that is robotic prostate biopsy. Dr. Han, the screen is yours.
Thank you very much, Dr. Allaf. It's my pleasure to be here today. I just wanted to share a little bit about my experience at Johns Hopkins, especially at Brady Urological Institute. The great thing about Johns Hopkins and Brady specifically is that there are a lot of people who are very intelligent and also dedicated to their work, but also many of them are so passionate about what they do. And one of them is Dr. Stonovich here. Dan Stonovich was born and raised in Romania, and he came to United States to do his postdoc fellowship in mechanical engineering. And we were fortunate to recruit him to our department more than 20 plus years ago. Since that time, he's been working with many people, including myself and also Dr. Allaf. When he was, I think he was in medical school, that he was able to work with Dr. Stonovich. And we have done a lot of work, and we are fortunate to be able to share some of them with you today. So he starts at the laboratory. So the lab is located at Bayview Medical Center, which is about 15 minutes from here. And then they have a full array of computers as well as softwares to be able to design certain medical robots based on the input from the clinicians like myself and Dr. Allaf. And once they are able to design the robot and they can manufacture them in their own shop. So they have different machines here. You have a big machine that can cut metal. And they also have 3D printer that can print certain aspects or certain components of the medical robots they want to produce. One of the robots that he and I have been working with is called TRUST robot. It's called, TRUST means transrectal ultrasound robot. So the ultrasound probe is this white part, and the rest of them are TRUST robot that's holding the ultrasound probe. And in this simulated movie that you can see that robot moves up and down, left and right, and in and out. And so you can do the image of the organ that he wants to take a picture of. After he made the robot, he was able to produce a pelvic mock-up, so simulated human pelvis. So here on the right side, you can see the bladder, bones, pelvic bones. The orange part is a prostate gland, and with some blood vessels around the prostate gland. And using that, we are able to do some experiments. So the TRUST robot not only moves the ultrasound probe, it tracks the location of the probe. So when you have a two-dimensional view of ultrasound, and then you combine that with the location of the probe, then you can generate three-dimensional view of the organ you want to image. In this case, the prostate gland and surrounding structures. It's a fairly compact setup. So you have a patient bed here in the patient clinic room. You have an ultrasound machine, which is just regular machine that any commercial provider can have. And you have an ultrasound probe and the TRUST robot, which is controlled by this computer setup, which is located right next to the patient. And then if we were to do a robotic biopsy, then I would be doing a biopsy, put the biopsy needle in and out of this robot. And then Dan Stonovich will be moving the robot and control it right next to me. To find out whether we can improve the cancer detection, he came up with a mathematical model so that if you have a very good capsule that is distributed throughout the prostate gland, then we would be maximizing the prostate cancer detection. After Dan came up with this model, then we did some more experiment using a prostate mock-up. So you have this image of the prostate mock-up, and then you have a simulated urethra that's passing through the prostate gland. And the robot would move gradually to the area to be able to get good sample of the target. But it will tell you exactly which direction the needle needs to go. And also it will tell you where to fire the needle so that you get the maximum sampling of the targeted area. And this is actually the actual computer screen during the prostate biopsy. And obviously we are not showing the patient, but you have a prostate image, ultrasound image here, and then you have a simulated image of the prostate TRUST robot, as well as the TRUST transrectal ultrasound probe. And as you go to different areas to do a biopsy, you will see the image of the ultrasound on the right side, and then you can see the needle that is going through to hit the target. And then after that, you go to a different part of the prostate gland to get the next target. At the end of the biopsy, you have composite image of the prostate gland. So this is a very rough outline of the prostate gland, and you see all the targets that the biopsy was able to perform, which is well distributed throughout the prostate gland. I'm just showing you this because when you do a human biopsy, which we done in experiment, we try to figure out how good the humans, or i.e. the urologists like myself, are doing a biopsy, whether the biopsy cores are well distributed like the robot can do, or how it looks. And what we found was there were certain areas of the prostate gland, the biopsy cores were aggregated, and there are certain other parts of the prostate, the biopsy was not done at all. So by using a TRUST robot, that we will be able to do a very well distributed biopsy, which is pretty intriguing. So the other thing that we can think about is, let's say if you're trying to target this one red dot, which is the target area, there are many ways that we can reach the same target point by moving the probe. So we try to find the maximum approach to be able to hit the target, but at the same time, minimize the movement of the prostate gland. So what about the order of the biopsy? I mean, you can say, well, why don't you just do all the left side and then all the right side? But it turns out that it's actually a little bit more complicated than that. So apparently it has a name. It's called traveling salesman problem. So when you look at here, let's say you assume there are 12 stores this salesman needs to visit. And you can go from 1, 2, and then go that side and that side, that side. But when you do that, then you're going to have an elongation of the traveling distance. So the algorithm can be used to minimize the distance that you travel throughout the whole biopsy. So the order of the biopsy may be not as intuitive, but as you move through the biopsy course, you can minimize the robot to move along the prostate surface, which is very helpful because when you do that, you minimize the prostate movement and deflection. And in this simulation, you have a simulated prostate, which is a hard-boiled egg. And if you look at this ultrasound probe in a magnified view, you can see this ultrasound is gliding along the egg surface, which is not flat. But in spite of this spherical surface, the ultrasound probe can move around and then be able to target different aspects of the prostate gland, which is really important for the patient comfort as well, because when the prostate is pushed, patient will feel it. But by moving or gliding along the prostate surface, it minimizes patient discomfort. In this experiment, that Dr. Sunovich was able to target different grid, and then as you can see, it really hits the target very accurately. And as we finished this project, we felt very confident that we will be able to do a human trial, and that's what we decided to do. So Dan was able to apply for a R01 grant, which is an independent research grant from National Cancer Institute, and he was granted the grant so that we were able to perform the biopsy. So in this trial, which will last 4 to 5 years, that we plan to do 500 patients in each arm. We're going to directly compare the prostate cancer detection rate between the TRUST robot and the other standard of care that we use called fusion biopsy protocol. And we believe that because the robot can minimize the prostate deformation, and then we can also maximize the biopsy plan, and that we will have a better cancer detection rate. What do I mean by personalize the plan? I'll just show you. First, in this one, this is actual patient, which you are not really seeing, but the accuracy and precision was very, very good for the biopsy in human trial. So when you have a patient, nowadays, when patient presents to us with the elevated PSA, we don't just directly go to the biopsy. We tend to get a prostate MRI because it has been shown to improve the detection of clinically significant prostate cancer. So in this patient, in the simulated prostate gland, there were 2 areas that look suspicious on MRI. So we can definitely target those using the TRUST robot. The question is, what do you do for the rest of the prostate gland? Do we just follow the regular template, or based on the size and shape of the patient's specific prostate, we can better distribute the prostate biopsy course, accounting for the 2 areas that were oversampled already, so that as you move the biopsy targets a little bit at a time, then you can optimize the plan and also improve the cancer detection probability. So when we do a robotic biopsy, all the templates are depending on the number of cores and the location of the area that looks suspicious on MRI, and individual patients' prostate gland size and shape. So based on that, the core biopsy core target location will change, which is something that we have never been able to do in the past. So that is a brief presentation of the research that we've been doing. I just wanted to share with you because this is a very, very small portion of the research portfolio in our department, which is rather extensive, but it is something that we enjoy doing. And then I'm so glad that we were able to share with you. Thank you so much for your attention.
Good afternoon, and thank you all for joining us in today's talk. I'm Dr. Charlotte Wu in the Division of Pediatric Urology. I'm going to be giving a very brief overview of robotic surgery in children with a focus on some of the reconstructive surgery the robot is particularly beneficial for. So Dr. Allaf hinted at this earlier, but modern robotic surgery is surgery that is performed with very small instruments that are placed into the body that are attached to a robot platform. The surgeon then controls that platform and also the instrument. This concept of robotic surgery first came about in the mid-1990s, and Dr. Parton in 1995 was actually one of the first to publish a series of the use of what's called robotic assistance in laparoscopic surgery at the time. These were among the first children to have undergone robotic assisted surgery, which referred to the use of robot arms to help with retraction or holding the camera during laparoscopic surgeries. Those arms were then in turn controlled by the surgeon with a foot pedal. The most well-known surgical platform now for the robot is the Da Vinci robot, and that was FDA approved in the year 2000. By 2001, the first robotic surgery had been done in a child using this full platform, where all the instruments were held up by the robot and then navigated by the surgeon. So in the first decade of its use in children, between 2000 and 2010, the most common pediatric robotic surgery was actually a robotic pyeloplasty, which is a surgery that pediatric urologists perform. So what are the main differences between open and robotic surgery? When we talk about these, we're talking mainly in the approach to accessing a specific part of the body where the surgery can then be done. So here's one example of obtaining access to the right kidney, which sits in this location here. If we were to perform an open surgery to operate on the right kidney, we would have to typically go into an open incision that is along the rib. And this is a fairly lengthy incision that then also involves cutting down through muscle and can be a setback for recovery. If we were to do this robotic, we could make 3 or sometimes 4 smaller incisions, each about 8 millimeters, to allow the ports to be placed. And that, in the same manner, would give us access to the right kidney. And then we would basically fill this space with air, which would give us some space to work with to then do that same surgery. So most surgical instruments, when they're first designed, are designed for adults. And that includes the Da Vinci robot and all of the instruments that are involved in its use. As surgeons that operate on children, we've had to work with these adult instruments to make these work in children. In the last couple of years, there's been significant advances in downsizing these instruments, as well as the ports to allow even greater benefits for the smallest patients that we have. But with that being said, it does remain true that the larger kids still seem to benefit the most, mainly in the school-age kids and particularly in teenagers. The benefits of the robot are similar to what we would see and expect in adults. The incisions are relatively small compared to the size of the patient. A faster recovery is possible, and there's decreased pain as well as decrease in the length of hospitalization stay. As the patient size decreases, that robotic technology can actually become increasingly cumbersome, and that's mainly related to size constraints. The docking and undocking of the robot, which is what we refer to as setting things up so that the patient is appropriately positioned and so that the location and depth of the instruments is optimal, can all be more challenging. And sometimes for the smaller kids, that also translates into greater operative time, which I've put an asterisk here, as that can be patient and size dependent. So when we put everything into perspective, this means that in smaller kids, because the ports are not proportionally smaller, recovery is often not much faster and operative times can be longer. So which children are going to benefit the most? This is going to be mainly dependent on the child's size and age. The robotic approach is possible in anyone who's roughly over 8 pounds. But as we hinted at earlier, on the smaller end of the spectrum, it can be more cumbersome and than beneficial. So typically anyone under 6 months old is not going to benefit as much, and open surgery is going to be favored. Anyone over age 2 or 3 will have greater benefit. That does mean that there is this kind of gray zone here between the ages of 6 months to about 2 years old, where length of surgery and surgical outcomes are really equivocal, whether they're done robotic or open. And for these patients, we typically will make a shared decision with the parents to weigh the pros and cons of each method. And these are some patients here. This is a 9-month-old undergoing robotic surgery. This is a setup for robotic pyeloplasty, whereas this is a 2-year-old whose family opted to have this done. And this is used with permission from one of our patients here. A very small incision can still be made in a fairly small child. So what types of urological surgeries can be done in children with a robot? So in kids, more so than in adults, we see anomalies that arise from aberrant development in the womb, and these are known as congenital anomalies. Congenital anomalies, also known as birth anomalies of the kidney and urinary tract, can account for up to 50% of kidney failure cases when they're left untreated. They're broadly divided into 4 categories and include conditions that affect the collecting system, or the portion of the kidney that collects the urine, or conditions that affect the parenchyma, which is a word for the functional portion of the kidney that contains the filtration mechanism, or they can involve abnormalities that affect the lower urinary tract, for example, the bladder or the urethra, and that can hinder urine drainage and the kidney's ability to drain urine down into the bladder. These lower urinary tract anomalies can often also be repaired robotically. In today's talk, I'm going to be focusing mainly on collecting system anomalies. So I'm going to focus on ureteral reconstruction, and one of the most common surgeries we do robotically is a robotic pyeloplasty, and this pertains to a condition where some children have an intrinsic narrowing of the area of the ureter, which is this tube that drains the urine, that connects pretty up high, that connects the upper part of the kidney to the lower part of the upper part of the ureter. And in these cases, we typically do what's called a dismembered pyeloplasty, where we separate the area that's narrowed, and we actually reattach the healthy upper ureter back up to the renal pelvis, so that the area that's preventing good drainage is fully removed. Another type of congenital condition that can affect the ureter is mid-ureteral stricture, and these are much rarer than UPJ obstruction, but they involve a similar problem, which is a narrowing that is lower down in the ureter. One of the ways to repair this is with what's called a ureteroplasty, where the ureter is actually cut longitudinally where it's narrowed, and then it's sewn back together horizontally, and that effectively opens up that narrowing. And you can see that depicted here as well. And another condition that can affect children is what's called a duplication anomaly. And this is where the kidney forms 2 distinct portions, an upper portion and a lower portion. And you can really see that here on this imaging here. This often means that the patient also has 2 distinct drainage channels with 2 ureters on that side. And that's going to be the upper ureter and the lower ureter. Some of the problems we see with duplicated collecting systems is a chronic blockage of one of the moieties of the kidney, and oftentimes that will be the upper moiety. And that upper moiety can lose function over time, and sometimes we do catch these kids at a moment where too much function has already been lost and can't be regained. And we can actually use the robot to, in certain circumstances, excise that non-functioning upper moiety. The other types of surgery that can be done for children with this condition is particularly those that have an upper moiety that drains into an ectopic or incorrect location. We would often see this in girls who can have chronic urinary incontinence, where that upper ureter is not properly draining into the bladder. One of those surgeries that we can offer is what's called a ureterostomy. You can see this is a robotic depiction of that surgery. There are two ureters on the left side that refers to these two ureters here. And we're actually using the robot to attach the upper ureter into the lower ureter so that the urine drainage can then be diverted into the proper location in the bladder. And that actually effectively cures the child's urinary incontinence. So I've covered only a very small portion of the types of robotic surgeries that can be done in children in today's talk by focusing just on the ureteral reconstructions that we do. But these are by far an area where there is much benefit to the robot, and that is particularly in kids that can be spared a larger incision and those longer hospital stays.
Thank you so much, Dr. Wu and Dr. Han, for two exciting presentations. And as the audience can see, robotic surgery can come in different forms. The Da Vinci robot, for example, which is what we see on TV and is kind of in our mind what robotic surgery embodies today, is actually not, by the true sense of the word, a robot, right? Because robotic things should do things automatically. They should have a prescribed procedure, and you press the button and the robot does everything. And I would say in medicine, we're not quite there, although there was a couple of good examples of a true robot. The Da Vinci so-called robot is actually a master-slave system. The surgeon operates arms that move inside the body, but if I move to the right, the robot will move to the right. So we're moving the technology. And same thing with Dr. Han's robotic, kind of approach, is that there's a robot that's doing some automatic information, but it's really guiding Dr. Han to the right area, and then only then does he sort of press the button to take the biopsy. And there's many other examples of robotic and image-guided approaches in urology that we're a part of, and all are equally exciting, and we are, I think, are moving towards more automated or automatic. So the question is, we have these new ways of doing surgery. How do we deal with training? The old adage in surgery, which is the surgical training that started here at Johns Hopkins at the turn of the century, was always the concept of see one, do one, teach one. That's the old Halstedian way of doing it. And thankfully today, even in open surgery, that's not the case. And if we go to the next slide, you'll see that part of our mission here, or a big portion of it, is not just to innovate approaches as Dr. Han and Dr. Wu are innovating in the research and patient care arena, but also in teaching the next generation of leaders. And so to that end, and understanding that the paradigm for training has to change, we were able to obtain a 5-year funding opportunity through a philanthropic gift to create a curriculum for these cutting edge technologies for our trainees. And the curriculum involves observation, assisting in the operating room, refinement of surgical skills in a simulation laboratory, much like they do when flying planes, and of course, independent practice. And these include things like online modules, inanimate objects, so, putting the robot inside of a box and moving things around. But more recently, and we used to do cadaver exercises, and in the past have even done animal exercises, but we've moved away from those because of various reasons. But one of them is refinement of technology in the area of training. And if we go to the next slide, we'll see a cutting edge way of doing this training. And in the slide, you see an operation being performed, and in the middle you kind of get the sense that there's something going on there, and the surgeon is operating with robotic technology, but they're actually doing an operation on a model, and this model is a hydrogel model. And on the left side of your screen, you'll see a bag of red dye that's connected to the model. And this model can bleed and has quite high fidelity to replicate what a human tissue looks like. And this is in collaboration with a doctor named Ahmed Ghazi at the University of Rochester, and we've been partnering with him on these models. And if we go to the next slide, I'll share with you sort of what that looks like. Our trainees can sit at a console, the robot can be docked, and they can be doing these operations on these models. Next slide. And this is, what these things look like. So they're lifelike models. And what happens is they can be generic or they can be catered to an actual patient. So a patient comes to us with a tumor in their kidney, let's say. You can then take the CT scan or the MRI and you could print a 3D mold, so a 3D printed mold of their organ. And then using these advanced hydrogel material, you can actually create a kidney. And as you see in the picture here, the kidney looks like a real kidney. It has a tumor on it. It's that little bump that's on it. There's an artery and a vein that go into it. And there's also a urine space in it. And you could fill the artery connected to a red dye and actually pressurize the dye so that when you cut into the organ, it bleeds in a pulsatile way. And so the trainee has to react in real time as they would in a real human being. And we're very excited for this new generation of training. And the other potential use of something like this is rehearsing or planning a difficult operation. So if this was a challenging operation, one can actually 3D print their patient's pathology the day before, 2 days before, and can actually perform the operation in this manner before performing the real operation and thinking through the anatomy and where the blood vessels are coming in, because it is that organ of that patient that's now 3D printed and perfused. So very exciting things in many arenas, in the research arena, in healthcare delivery, and what's available to patients today, and then in how we train and maybe rehearse for surgery. I'll remind everyone to put in questions if you haven't already. And I think we're ready to pose the audience questions and get some of these questions out to our panel. Here's a question, and maybe we'll start with a very simple one to Dr. Han. How much does a Da Vinci robot cost? How much does the robot you're developing cost? And can you comment on the cost of robotic surgery in a already strained healthcare system?
Thank you. So I believe that Da Vinci robot costs $2 to $2.5 million for the new ones and new models. And the robotic surgery, definitely there is an increased cost in terms of disposable instruments as well as the robot. At Johns Hopkins, we have a better system, in a way that we are not purchasing them, but at least we are able to use a lot of robots leased from the company, so that it's more manageable, and then the access to robot is a lot easier. And there is an additional cost because of the disposable instruments, but in spite of that, I think the other benefit for the patients is that you have a fairly significantly improved recovery phase. So pain medication use is down, and the patients are able to go home a little bit earlier than the typical open operations. And the other benefit is that you have a less likelihood of getting a transfusion, which is an added benefit for the patients. Obviously, there is no perfect I wish that there is a perfect option for us to be able to do more surgeries with more manageable cost increase. And I think robotic surgery is one of them. In terms of the cost of the robot that Dan developed, we have not planned to commercialize this, and we are doing more of a research project. But I do not know how much it will be if we have to mass produce it.
Thank you so much, Dr. Han. And I would add that, right now, from the master slave system standpoint, Da Vinci is a monopoly, right? And we're all excited because there are other companies like Medtronic and Johnson and Johnson, Ethicon, and others that are trying to enter the space. And I think the more options patients and hospitals have for robotic surgery, that will drive some competition, which will spearhead innovation and differentiation, which is going to be good for patient care, but also will drive, cost down. So an exciting time when we see all of this. To Dr. Wu, I'll ask you this question. What happens if you're operating and the machine malfunctions or loses power? Can you discuss this aspect of using a machine during surgery?
Yes, that's an very unexpected circumstance, but it's something that we often will think of and just prepare mentally in advance. This has not personally happened to me, but certainly you want to be well equipped with the ability to convert to an open surgery. And so that's one of the you have to kind of think on your feet. And so it depends on where you are in the surgery and what there is still left to do. You can often try to convert to laparoscopic, so you can still maintain your small instruments and your small incisions, and just rather than docking the robot, place your instruments inside and navigate that like a laparoscopic surgery. If you're really not that far along in that surgery, and for example, you've only made one small incision and you haven't really even docked the robot yet, then you might want to just consider converting that to an open surgery if you really have no other resources available for you.
Yeah, thank you, Charlotte. And one thing we're spoiled with here at Hopkins is, number one, the malfunction rate of these robots is obviously very, very low. I think it's on the order of about 0.04%, where when you're operating, an arm isn't moving. It's never sort of a dangerous situation. But we're spoiled because we have 12 robots at Hopkins, and oftentimes we can even just bring in another robot in, which a lot of other places don't have that luxury to do. Here's a question that I think is germane. We talk about prostate, we talked about pediatrics. Has any work in robotic surgery been done on bladders? I'll ask it to both Dr. Wu and Dr. Han, because the question asks, has either augmentation been performed, and that's probably in the pediatric population, or to treat bladder cancer? And maybe Charlotte, you want to take that first, and then Misop can fill the gap with the adult cancer question.
Yeah, absolutely. So there has been, there are quite a few series on robotic augmentation cystoplasty for pediatric patients. So I think the factor here is still the constraint on size. And so for a surgery like that, you really have to be able to swing from one side of the body to the other side. You have such a wide range in what you need to be able to see and to be able to work with. And for the smaller kids, so we start doing augmentation cystoplasties usually by the time the child is school age, and you really don't have that much space. But this is a surgery that's been done. It's in increasing numbers, and I do think this is going to catch on. One of the ways that we can get around this too is by doing portions of the surgery robotic, so that you're spared from that bigger incision, and then converting to an open portion just to do parts of that surgery. And I do believe that's what they do on the adult side too. And I think Dr. Han can speak more to that.
Thank you, Dr. Wu. Robot has been used in bladder cancer management, especially when you perform radical cystoprostatectomy or radical cystectomy, and people can remove the bladder using a surgical robot. The difficult part is being able to take care of the urine conduit or neobladder, so that you can produce a neobladder or conduit inside of the abdomen as a part of the robotic operation, which takes quite a long time. So to prevent that, we have revised it so that you can remove the bladder using robotic surgery, and then make a small incision and do the rest of the operation so that patients can come out of the OR in a reasonable time and recover quickly. Since a lot of patients who have bladder cancer tend to be a little bit on the advanced age patients, so that approach has been working very well for us.
Thank you. A question, and I can take a stab at this one. A key factor for success for robotic surgery appears to be the number of surgeries successfully performed. What is a rough number that would increase the likelihood of a positive, outcome? And I would say that the prevalence of robotic surgery for different pathology is different. So, for example, in the pediatric world, where fortunately, these birth defects and problems are rare, somebody who does 3, 4, or even 5 a year could be an incredibly high volume and skilled person to do them. For the more common procedures like what we, prostatectomy, there's definitely a ton of data that supports the notion that high volume surgeons in a high volume center leads to a more positive outcome. And depending on the study, it would appear to require at least 5, potentially 600 cases in certain studies to achieve sort of optimal outcomes. Although, as I can attest to, and I'm sure Dr. Han can, even after we've done 2,000-3,000 of these, we learn every day. But I think for a robotic prostatectomy, several hundred. For some of the other procedures, like in pediatrics, I would imagine that the number for a successful outcome is less. And the reason prostatectomy is a unique operation, A, it's plentiful, but 2, there's the result of sort of just making it through surgery and healing, but then the functional outcomes that require, nerves to be spared and things like that, which is something we do quite often here. And I'm privileged to work with people like Dr. Han, who at this point have done thousands, of these. Another question for Dr. Han, I would say, since it's a question about a large prostate. Sorry, Dr. Wu. For the kids, what treatments do you offer for men with very large prostates suffering from enlarged prostate or BPH, and any problems with these approaches as men get older?
Well, thank you very much for that question. So one thing that we have been doing is what we call simple prostatectomy. So radical prostatectomy is removing the whole prostate gland, including the capsule or the shell of the prostate gland. The simple prostatectomy, we leave the shell or the capsule of the prostate behind to minimize the side effects. So we can kind of scoop out, using a surgical robot, we can scoop out whatever is obstructing inside of the prostate gland, and while leaving the structures behind. And we have taken care of patients in their 80s, but it will really depend on how healthy the patient is and what other comorbidities there is. Because even if the patient is in his 80s, that if he is pretty healthy overall, we can consider operation like that. But this is very similar as in terms of a one-night hospital stay. They go home with the catheter, and catheter comes out about a week after the surgery.
Thank you, Misop. A question on, has remote surgery been considered, and what are the issues associated with that? Dr. Wu, do you want to take a stab at that one?
Yeah, so I have heard of these being done, and I do think that actually I read somewhere that originally the idea of robotic surgery was actually in the battlefield, so that you could have a surgeon remotely and have a robot set up on the battlefield to do these types of complicated surgeries from someone who might not be on site. But it hasn't quite materialized to that point just yet. One of the considerations is that the surgeon is not in close proximity to the patient. So, if you did get into a situation where you really need some tactile feedback, or you need to be present to do something at the bedside, being so far away is definitely a hindrance there. So I think that's something to consider. And I think the technology is also is evolving, but is not quite there yet.
Yeah, I think you're right. There certainly has been remote surgery being performed, and it's been an evolution initially. And research from Hopkins actually started all of this with what we call telementoring projects, where you would beam in to an operating room and be able to mentor someone through a case by drawing on the screen and sort of helping someone along. But certainly robotic cholecystectomy has been done to removing a gallbladder and other operations. The barriers to them have been bandwidth, liability, and licensure. Those have been sort of the big, barriers. Bandwidth has gotten a lot better. There are licensure issues being in sort of a state and operating in another state, but certainly this could have great applications to have someone like Dr. Wu with expertise be able to treat someone in a rural environment with maybe a physician there on standby for an open approach should the robotic approach not materialize. But it's certainly a very interesting area of research and development. There are a couple of kind of similar questions. Maybe one question is about infections after robotic surgery, specifically prostatectomy, urinary infections. I would say that that's rare, but not unheard of. We see it from time to time. And usually the key is to just make sure that we're emptying our bladder completely. And certainly in the early going after radical prostatectomy, we do see infections because you've had a catheter in and it's a man-made connection. And same thing even after bladder cancer, there's a question of a cystectomy. We do see infections. If the infections get into the meat of the kidney, they can be quite problematic to treat as the patient is experiencing in this. But the key is to just make sure there's not an obstruction, because blockage can lead to more and more infections or stones or foreign materials, sutures and things like that. So an endoscopy usually would help if that has not been performed. Excellent. So I think with that, and we're right on cue here with the time, I want to once again thank Dr. Han and Dr. Wu for joining us this afternoon and for laying out your investigations and findings with such clarity and promise, and for answering the many excellent questions. And of course, a big thank you to all of our guests who joined this webinar and for your continued support of the Brady and Johns Hopkins Medicine. Without you, our work would not be as impactful or meaningful. If you have any questions about how to support us in any of these efforts mentioned today, please reach out to the email, address, or phone number listed on the screen. And once again, thank you for spending this afternoon with us. I hope you found it helpful. And we will have many more Urology Speak events, and we hope to see you all there. I hope everyone has a great rest of their evening. Thank you so much.